Lunches. Thank you, everybody, for coming to lunch for the Junior Surgeons Committee. We are going to be having a session in this room in about 2 minutes. So maybe we could finish up our conversation, sign the sheet, and move on to the next part of the meeting. Thanks.
Good afternoon. We're going to go ahead and get started. My name is Sunil Givergis, and it's my pleasure to welcome you to the How I Do It teaching session. I know that people are finishing up lunches and other sessions. We'll just ask them to take a seat as they come through. It's a pleasure to have people as they mill in. It's my pleasure also to be partnered here with Ibera, please.
Good evening, everyone. Welcome to this session, and thank you for having me here.
Well, it's going to be a great session for those of you who are interested in education. Would ask that there's Dr. Kelly Collins coming up. Thank you. We're really excited to have this session. I think part of the dynamic here that we are trying to embrace is that there are so many dimensions to being a good surgical educator. And I by no means have any mastery in this, except to say that what you're about to see in this panel is a phenomenal amount of wealth of knowledge in the actual education of fellows, residents, and students. And in the end, that's what it's all about, in my humble opinion, is spreading the knowledge and the expertise and the joy of learning to our colleagues. I will say that in addition to the people you see in front of you, we also have two speakers that are going to be visiting us from Zoom, and will be coming in for hopefully a vigorous Q&A session to immediately follow. So if I can ask my friend in the AV booth, I apologize for not knowing your name. Would you mind closing one of those doors, or maybe both of them, just to decrease the sound? Thank you. All right, again, it's my pleasure to begin this session with our very first speaker, Dr. Carol Ann Moulton. She's visiting us remotely from the University of Toronto. Dr. Moulton is a graduate of Melbourne University Medical School in 1992. She proceeded to complete her basic and advanced general surgical training affiliated with the Austin campus in Melbourne. She completed a clinical fellowship in laparoscopic and upper GI HPB surgery at St. Vincent's Hospital in Melbourne in 2002, and then traveled to Canada to complete her HPB surgical oncology and clinical fellowship in Toronto General Hospital in 2003. She undertook research studies and surgical skills training as a graduate student in health professional education as a fellow at the Wilson Center and the University of Toronto, and received a Master's of Education in 2006. She's continued as a graduate student enrolling in the PhD program with the Institute of Medical Science, studying surgical judgment, completing this in 2010. She's currently associate professor at the University of Toronto and staff surgeon with the Division of General Surgery, University Health Network. Her clinical practice is devoted to HPB surgical oncology. She is appointed also as scientist in the Wilson Center and continues her program of research studying surgical judgment and the social psychology of surgeons. She'll be visiting us remotely at the end for Q&A, but we'll now play her video. Thank you.
I'm presenting this from Toronto. I'm sorry I couldn't join you in person. I'm holding the fort here in Toronto, and my colleagues are down there enjoying the fellowship, I hope. I was asked to give a talk about how I do it, and essentially how I assess trainees for starting the case or doing the cases in the operating room. I thought I would actually present to you a framework rather than a point list. Like, obviously, when I think about starting a case, I think about, reputation. If I'm working with a fellow or a resident for the first time, I ask questions like, how are they? Or, are they good in the operating room? How are they with their hands? I mean, we do that. But I also make assessments, more so, I think, myself. And so I thought I would present to you a framework that's a little bit biased because it was my PhD work, but it really is the way I think about how trainees are performing in the operating room. The PhD was centered around a construct called slowing down when you should. So this was the transition that a surgeon makes from a relatively routine mode of operating to that of a more effortful mode of operating when the situation requires it. So we run into something that's unexpected, we are uncertain about what we see, or there are critical steps in an operation and we actually slow down and focus on the task at hand. Now, the slowing down doesn't necessarily mean that we slow our hands down, but cognitively, we switch to a more kind of analytic, thoughtful brain rather than the non-analytic routine brain, and we slow down appropriately and focus on what needs to be focused on. That is the critical part, I think, for my assessment of trainees. And this is how I view trainee surgeons. I think it's critical for appropriate judgment. And so I want to explain a little bit about this phenomenon. As expertise develops, we know that we work through different phases of automaticity. So a novice would start with suturing a wound and they would take a lot of effort to do it, and they can't multitask. They can't think too much if you ask them questions. Whereas as we go along and we develop expertise, we switch to a more automatic mode. So a surgeon who's sewing up the wound can talk about many different things. We can listen to music. And so what we've actually done with the process of automaticity is reduce the amount of cognitive load, and we've freed up other cognitive effort in the process. So that's the process of automaticity. This is displayed in a little bit of a different way. The novice on the left-hand side has the primary activity where they're really focused on what they're doing, suturing a wound, whereas an expert, a fellow, a surgeon in this case, could just sew up the wound and have this freed up capacity. One of the things that causes us to then move back the other way in terms of going from a routine mode where we know what we're doing and we're doing the same kind of things all the time to that of a more effortful mode is this phenomenon of situation awareness. Situation awareness is being aware of what's happening in the moment in any given space or time. And this is another kind of broken down situation awareness a little bit and differentiating it from decision making. The box on the left-hand side is how we perceive things. So the ability of ourselves to perceive something. So for example, we are coming through the abdomen and we are opening up the peritoneum and a laparotomy, and we see something that, you know, is unexpected. We might see kind of thicker tissue below it, and we might have to pause and think, have they had previous surgery? You know, so you're trying to understand what you see, and you're trying to figure out what that means for you. So that's the ability of slowing down, and now you're kind of gaining situation awareness around that event and what that might mean for you. Then you make a decision. So this is kind of differentiating it from the decision. But for the moment, I'm just focusing on the left box, as opposed to kind of a different way of thinking about it, saying this patient has had previous surgery, and I'm going to be cautious when I go in, and I'm going to be looking out for you know, adhesions as I go in. And this is more of a top down, like I'm aware of the situation, and now I'm trying to make sense of the things that I'm seeing. I'm looking out for and anticipating things. So this situation awareness can be achieved kind of top down and bottom up. And I think these are the things that I'm looking for in my residents, so that when they are in a relatively routine mode, or when they're actually kind of going in and opening up a patient, they have that ability, they've thought about it, they have the ability when they transition to focus on the things at hand. So this automatic and transitioning to a more effortful is that slowing down process, where, you know, relatively routine, now transitioning into a more effortful process. When we studied this in surgery, we interviewed many different surgeons, and we observed actually HPB surgeons in the operating room. We found that there were two big groups of slowing down moments. And I'm going into this much detail because I think that it's important for us to think about how we structure it, and how can we put words to it so that we can reflect on it, so that we can teach it more explicitly, and maybe even assess it more explicitly. So I think this is kind of what I do on a day-to-day basis. The way I see trainees and the way I see them operating, I'm looking for their ability to slow down. And so let's go into it a little bit. There's two main buckets, which I think are important. One is the planned, and the other one's the unplanned or the responsive. So let's talk about the planned. The proactively planned slowing down moments can either be procedure specific or the patient specific. So in this particular case, I say I'm doing a right lobe. In this particular case, in right lobes, I slow down at the right hepatic vein and the right bile duct and the right portal vein. So you can have your slowing down moments that are proactively planned, ones that you know that you're going to slow down when you get to this part of the procedure. But they can also be patient specific. So they're planned. You look at the patient, you say, in this particular patient with the tumor on the middle hepatic vein, I'm going to slow down as I come through the liver in these areas. I'm going to be looking out for these things. So that's kind of a proactively planned template of your slowing down moments in the case. And that's what I look for when I'm actually looking at, you know, whether I can leave residents or fellows to do parts of the procedure. But the other type of slowing down moment is the situationally responsive. So these are the things that are unplanned. These are things that are novel, we haven't seen before, they're unexpected, and they are times when we feel uncertain. And so these things happen to us. The key, I think, is to try to make everything planned as best we can, to think about it, to plan it as best we can. But when we can't do that, then we respond to whatever we see. And so we also have to have some of that freed up cognitive resource going back into investing in the case to make sure that we can respond appropriately. So for sure, I'm looking at this. This is how, you know, when I'm going through this, because I think that's how I try to teach it, like, where are you at in terms of the game plan, or in terms of planning your slowing down moments, and how are you with responding to it? And through that assessment of you, I'm trying to figure out how much can I leave you alone. So as I said, we studied this in the operating room. We saw many different manifestations of the slowing down phenomenon, which I won't go into all of the detail here, but we certainly saw the different phenomena of stopping versus like removing distractions, versus focusing more intently and fine tuning. So those were the four manifestations of it. And so you can see people slow down. I think that's important. And you can see it because they're focusing, right? They're kind of routine and listening to music, or talking about something else, and then focusing more intently and withdrawing from a conversation. So coming back to this, if you think about the two groups of slowing down moments, how I make decisions is both the proactively planned, how the resident is planning this case and how they've shown me that we're on the same page, and then the responsive, how much do I trust that they not only will perceive the things that we need to perceive, so they'll have accurate situation awareness, but they'll also call me. So that's also part of it. They'll call me when they need help. So because we were studying this in the operating room, we saw that the surgeons were slowing down, and they were kind of in that slowing down framework themselves, but they also had a trainee and they were also operating through the hands of the trainee. And so we were very interested in this, how do we ensure slowing down when we're the surgeons and the trainees now are the ones that are holding the instruments, and we're trying to kind of develop autonomy in our trainees. How does this work? And we saw that both in the interviews and in our observations, that control was a really big part of this. Surgeons needed to retain control of the operation, even if they gave up some control of the case, they still had to feel like they had control of what was happening, if that makes sense. And I'll explain a little bit of what we actually kind of learned as we went through. So there's this thing called the control dynamic, which I'll talk about briefly. There's this understanding for how we negotiate that control with the trainee. There's also complications of control, which we won't go into today for the interest of time. But the control dynamic is just because we are operating from the other side of the table. I'm operating on one side, the trainee has the instruments, they have the cautery, they are dissecting. I'm obviously doing a lot from my end. So this is that dynamic that it's constantly changing. It's not just like you do the case or I do the case. I control how much trainees are looking at and how much they do. So there's definitely this control dynamic. You can kind of think of it as maybe a fishing line or a leash. You can kind of let the leash out, you can kind of pull it back. And so this dynamic is happening all the time. On one extreme, I'm completely hands off. I trust the residents or the fellows to either do the case. And again, that assessment's made by, they've planned it. They have the plan slowing down moments. We're on the same page. And I am confident that they'll actually slow down when they should. The other extreme is that I take over, that something's happened, that I don't trust them or that I can't do it and I take over. And it doesn't happen very often. In fact, almost never that I would take over completely. And then more in terms of the negotiating control, I'm establishing control initially, or I'm trying to figure out how much they can actually do and then maintaining control. So let's talk about that for a little bit. The trainee, how much is the trainee prepared for the case? And what is the game plan? So is the trainee calling me beforehand and saying, I thought about this case, I've looked at the imaging, these are the places where I think we're going to have trouble, and this is my plan. That would be fantastic. It doesn't happen all the time, but it's great that it actually does. And then there I see, not only do I think, great, you've done your due diligence and you've done it, pat on the back, but it's more that, okay, now I can trust you. It's entrustment, right? And as Rebecca Minter and her group talk about. I need to know the fellow or the resident is on the same page as I am. Otherwise, I don't trust them to start the case. It's kind of essential. But if you look at it from the proactively planned moments, that's what it's about. You're planning, I'm planning, and they are the same. We may not have the exact same slowing down moments. In fact, we won't. But we've thought about the case and we can talk about these moments. This is what happens when we don't plan for cases, or the residents not planning for cases. We kind of take offense to it, and we can kind of, from a culture perspective, we say, well, you can kind of, just bugger off and not do the case. But that's not. I think it's because it's deep rooted in the fact that we know that you are going to learn more if you are prepared for it, and I can't now trust you because you haven't prepared for it. So how do we maintain control? A resident has control of the operation in one way or the other. I'll intervene to make sure I have control, not necessarily because I'm physically doing all the maneuvers, but I can set the pace, I can control what everyone is looking at and stuff like that. And so what this kind of quote told us, and for sure what I experience when I'm doing it, is that my hands can be in a particular position, say the Uncinate process of a Whipple. I can protect the SMA and maneuver my hands so that I have more control at that point in time, even though the resident is doing it. So there's lots of little maneuvers that we learn on this side of the table to think about this kind of control dynamic. So again, how do I do it? It's this idea of maintaining control, but thinking about it in terms of the actively planned and the situationally responsive moments. And when it works well, it's like a dance, and we enjoy it. We even experience this this sense of flow, or the phenomenon of flow. But if we don't enjoy it and it's clunky and we're not on the same page, it can be awful. Thank you very much.
We'll wait till the very end for questions, and we'll have her join remotely as part of that. Dr. Moulton, thank you very much for staying on the line for the remaining part of the panel. Our next speaker is Dr. Kelly Collins. Her topic today is engaging multiple learners at different levels. I've had the pleasure of knowing Dr. Collins for probably 15 years now. She's by far the most compassionate, kindest transplant surgeon I have ever met. And I'll be honest, I'm really looking forward to hearing this because this is a topic near and dear to my heart. So Kelly, please join us.
Oh, you're a bit taller than I am. So I want to thank Sunil and the AHPBA for giving us some space to talk about education, and I'm excited to see so many people who are engaged in this discussion. I have no disclosures other than I have no formal training in education theory. So these are just some of my thoughts on the subject. I'm going to start by taking a few minutes to talk about content, context, and capacity of surgical education, and then move into how to take these into consideration when creating strategies for engaging multiple learners. The paradigm of surgical teaching has long prioritized development of technical skill and clinical knowledge through intensive direct exposure and relatively autonomous practice. But as the culture has mandated a shift from early autonomy and practice, it requires that we adapt teaching styles, understanding that they cannot rely on this model in which we were raised. For many of us, the operating theater is often a place where we consistently have a captive audience. However, it is also the context in which there are many factors demanding our time and attention, and engaging learners, particularly at multiple stages, can become overwhelming. In order to successfully meet the training needs of the new era while appreciating competing demands, we need to understand specific training needs, distill content, and pair with context, and be intentional with strategies to keep learners at multiple stages engaged, ensuring that early trainees don't fall out of the conversation entirely, and that senior trainees remain appropriately challenged. I think this can be framed by the 5 W's, and in full disclosure, this isn't something I'm a master at, but I'm working to become better. A large part of my teaching role has been in the training of fellows. So when I'm tasked to teach other levels of learners, the first thing I have to do is remind myself what is appropriate to that level of learners. And thankfully, there's a wealth of resources currently available to understand trainee level appropriate goals and guide creation of content. In addition to this wealth of trainee-specific resources, another resource we can use to create our educational scaffolding is the ACGME core competencies, which regardless of how you feel are best implemented, they can create a framework from which we can think about all of the components that we're responsible to entrust in surgical education. And by understanding this content, it may help you map out where you can incorporate these things into your practice, or where you can highlight the things that you're already doing. We all have variances in our practice, but we should take time to take inventory on how education occurs on our services. And I don't mean creating a list of the concepts that you expect trainees to master by the end of the rotation, but creating a map of how, when, and where the content will be delivered. By deconstructing these concepts, we can map out how to specifically target them, emphasizing the importance of pairing content with context and trying not to overburden a single setting or miss an opportunity. It also may be helpful to explicitly identify what you are teaching and when. Explicitly outlining a plan gives you and the team direction and keeps you focused on the task, which may allow you to enlist others in the teaching endeavor. Optimally, there would be a dialogue where trainees may help set the agenda. For example, if you come in service on Monday, you can state, this week on rounds, we're going to focus on donor considerations and kidney transplantation. Junior resident, on Thursday, maybe you could talk to us for 5 minutes about KDPI. On daily rounds, we'll plan to discuss the donor details for each patient, so please be prepared for that. The first specific example I'm going to discuss was a remedy for balancing my own stress at the beginning of living donor liver cases while recognizing the unique training needs in these cases. The former setup involved me, brought with stress, walking into the donor OR and being swarmed by trainees looking to discuss the case. The strategy created a dedicated case conference the week prior, allowing for trainees to have dedicated time to understand and review important aspects, as well as gave me the space I needed immediately prior to the complex case. We also need to acknowledge that trainees face similar competing cognitive demands, as mentioned a little bit by Dr. Moulton, in their learning environments. We need to respect their limits and employ strategies to manage cognitive load while capitalizing on context. For example, imagine it's your fellow's first pediatric liver transplant. And while you're excited to delve into all of the aspects of this nuanced patient with the 8 hours of a captive stadium seating audience, by planning ahead, you can effectively engage each of them. And while it may be tempting to dive in, asking someone to explain the pathophysiology of biliary atresia, I would argue that that's generally sort of out of context for the situation, and specifically for the fellow, it's not really helping them reach the goal at hand, which is technical. So try to plan ahead and have specific go-to topics for each potential group. You can reuse your stock questions over and over, but be specific to their level. Take advantage of contextual learning opportunities. And in the operating room, I would say these are largely anatomic or technical and account for the potential for overload. Another opportunity is to take the content out of the specific context where it can be busy, overwhelming, and stressful situation. Our division meets for 2 hours every Monday morning with the entire team, and we go over all of the planned cases for the week, imaging, surgical approach, discuss any pertinent findings, as well as review a curated list of cases from previous weeks. This is repeatedly cited as the fellows by a very helpful activity. This is one of my favorite activities or examples. This started out as a way for me to try to explain to the fellows options for cable clamping with Tupperware and Penroses, and it ended up being a recurring theme of mock liver transplants that we would do on quiet afternoons at Henry Ford, where students, residents, and fellows would first discuss implant techniques, and then everybody had an opportunity to experience sewing in the liver. Final example is something I did recently with the residents. They had the typical learning hour where all of the residents of different levels are present. So we did activity cards based on deceased donor transplant concepts, which included data questions, drawing anatomy, and then for the upper level residents, they would describe the procedures. Why to do these things? One, at its most basic, it's our job. It's gratifying, it's appreciated, it makes a difference, and it can be fun. Thank you.
Thank you, Kelly. I have to admit, and in my enthusiasm to introduce you and hear your talk, I completely skipped over your formal introduction. So I'm going to do this in reverse. Kelly Collins is a transplant surgeon who's currently at the University of Wisconsin as surgical director of pediatric and kidney transplantation. She's the University of Wisconsin Health Surgical Director of Pediatric Liver Transplant. She received her MD from Medical College of Wisconsin, training at UK and Medical College of Wisconsin in surgery, and a fellow at the distinguished Washington University School of Medicine, where she follows training by 2 presidents, President Chapman and our most recent President Doyle. So that's just a small introduction of what you deserve. I apologize, I skipped over that. All right, our next speaker really needs very little introduction, but I'm going to read it. Dr. Rohan Jayaraja is HPB and HPBA through and through. Dr. Jayaraja is currently the director of the GI Surgical Service, as well as the program director for hepatopancreatobiliary and advanced GI surgery fellowship programs at Methodist Richardson Medical Center. He serves as the chair of the Department of Surgery at TCU and at the UNTHSC College of Medicine, School of Medicine. Trained at the University of Chicago and attended a liver transplant fellowship at Baylor University Medical Center in Dallas. He served on the faculty at UT Southwestern Medical School and rose to the rank of associate professor. He is the former president of the Fellowship Council, past chair of the HPB Program Directors Committee and America's Hepatopancreatobiliary Association. He serves as secretary for HPBA. He's also authored numerous articles and chapters, and it's been just a pleasure to know you for the last 10 years. And as a fellow DACY, thank you, and I look forward to your comments.
Thank you so much, Dr. Givagis. So such a pleasure to be here today with so many friends in the audience. So I was tasked with the talk of the struggling trainee, and I wondered for a while if our chairs of this session thought I was a good one to give this talk because I was a struggling trainee, I'm sure. So I have some disclosures here, none of which are relevant to this talk, and I'm willing to take on more if anyone's out there. So the overview of the talk, I'm going to look at the aim of training, why do we train, and then look at the areas of struggle within our trainees, and then a word about the new world that we live in today, which is different than many of us trained in. And I think we need to embrace it. My daughter is a human rights major at SMU, and so I get this earful every day about appropriateness and things that I should be doing. And it's something that we all need to work at because it is really important. So 3 areas of potential trouble in a trainee at any level, really. One are there troubles in clinical decision-making? Are there troubles in technical skills? Or are there troubles in research and inquiry? And I believe that all 3 of these are important. You also have to decide, is there objective evidence? Or is this you that has come up with the idea that this person is struggling? And you all know from your training, there were 2 kinds of chief residents, right? Ones that ate their young and ones that protected their young. So you have to figure out if you are just that person that is finding everything wrong in the people around you, which is very easy to do, especially if you are insecure. So you have to figure out, is there objective data to support the fact that the trainee that you're working with is struggling? So a quote from my son, Dad, work on what is in your control. So I think this is really a good thing because even within the scope of the society, we have to work on what is our control. So think about what is in your control. And my mom reminds me that I had a really bad temper when I was a kid because she was yelling at me the other day. And I said, Mom, you can't yell at me. She's 91, by the way. And she said, well, you had a bad temper when you were a kid. And I said, no, but I've changed that because I realized that when I lost my temper, the other person won. Please remember that, okay? In the OR or wherever, if you lose your cool, that other person is won. So it really helped me level set. So clinical skills. So this is a quote of mine. I would rather have a doctor with common sense than brains, because I am like super commonsensical. I have a processing issue where I cannot. So just to give you an example, I can't memorize a Bible verse or a poem. My poor wife, I'd love to recite something to her, but I can't remember it. I can't even remember our zip code for our card. I literally have, like, if it doesn't make sense, it doesn't stick. So that's actually a gift in other ways, because those of you that have been in the OR with me, we never do the same case twice, right, Terrence? It's always a different approach because I'm just going to do what makes sense to me. Find point A, find point B, and connect the dots. If A is not there, then find point C. And what that means is, do they have the knowledge and do they have the common sense? Because you need some knowledge, right, in order to make the decision. And so where is the knowledge? And I can barely read this, but you need some knowledge, right? For a question like on rounds, what chemotherapy agents would you use for borderline resectable pancreatic cancer? But then there's common sense, right? The patient has blood coming out of their drains and is hypotensive. What should we do next? That takes no knowledge. That's just that everyone is telling you that patient's bleeding. And so is there a processing issue, right? I have the knowledge, but I cannot apply it. So not all, my sister always says, all brains, but no common sense. Right. So I have all the data behind the data for which agent to use in this mutation for pancreatic cancer, but I can't tell that this patient is resectable and needs a head resection, not a tail resection. Right. So is there time to read #MyResidency? Right. So I famously did pretty poorly. I will not state the number on my second year in-service exam. And one of the reasons, and I'm going to own this, but one of the reasons is I was rounding with an IV in myself with a temperature of 103 the day before in the ICU and literally got sent home by the infectious disease doctor because my faculty wouldn't send me home, you know. And so thankfully things have changed. I never want to go back to that mode of training. It should never be like that. And not retaining, right? So I read it, but I cannot remember it. So for me, I have to work with association, right? I can't, like even names, you know, if I meet, you know, a Ted, I'm going to be like Ted Baker. Okay, I love that designer. Okay, so I'm going to remember that name. Okay. And then common sense, this I think is the hardest thing to fix in a trainee or in oneself, right? Because, you know, they're responses that need very little knowledge, but it's what your medical assistant is prompting your fellow or trainee to say. You know, you're like, oh, so what would you want to do next? And the medical assistant's like, admit them, you know. And so that doesn't take much. That's commonsensical, you know. Knowledge base is not that key here. Well, we spend so much time on the technical skills, right? And I want to say something that's a little bit probably risque to say in this audience, but I do think that the rise of acute care surgery in training has changed the way that we now have trainees, both on the resident side, but also on the fellow side. Because truthfully, in many programs, so this is not true for all programs, but many of our trainees are spending a fair amount of time on acute care. And what that means is things have really changed because everyone blames the 80-hour work week, but it's not really that. We focus so much on the OR piece because we're proud that we've kept the OR piece constant, number of cases, etc. But what you get in fellowship is really that continuum of care, right? The pre and the post, the seeing the same patient through that, which even if you try as a resident, is not possible because you're rotating services, you may be rotating shifts for that matter. So it becomes difficult, and these are some things that fall into the fellowship realm at this point. And this is kind of, I think, what has really, really, really happened. And I must say, I've borrowed this concept from Dr. Osman. Those of you that have met him, that's my partner. He's super honest and has the greatest insight, you know, and this is what's happened is that residents are rotating, but now faculty are rotating too. So as a trainee, you may not be thinking about where to put that stoma because it'll be a completely different team that's taken that down. And that's very different now than what we have to train because we're following those patients for the throughput. And those of you that are out in practice, I think that's one of the hardest things to learn is actually what I do today may impact a year from now. You know, actually, Dr. Hagopian and I were talking about a bile duct injury that I didn't do perfectly. She has a BMI of 50. And, you know, it's one of those cases where you're like extra long instruments with, you know, those of you that train with me are like fingers in the hole where like way back here trying to solve this thing, you know, and it wasn't perfect, but my mind was going through, is it enough? Am I going to be worse by taking it down? And what are the consequences a year from now, right? Because I might commit in this patient to a stricture down the line. And those are the kind of things you have to verbalize and get across to your trainee also, right? Because you know it's going through your mind. You're so used to this, but you've got to make all of those dots meet. So you've got some specific fellow-related things, right? You know, that are technical. One, can you tie with a 5-0? Can you make it so that both ends are equal, right? Do you need a spritz to tie, you know, a squirt? Can they turn their wrist? One of my favorite things, right? Can you turn your wrist? And can they do a vascular anastomosis? Those are some given things that you cannot assume, but may or may not be present. And that's why to me, and again, those of you that have trained with me or been in my OR, Shana, know that, that it's the rate of the rise, right? It's not where you start from. So these are two fellows, just to give an example. And, one starts with a terrible, background, but rises quickly. The other one comes with a lot of experience, but doesn't change. I'm looking for that rate of rise. And one of my favorite things is to look at our fellows, and they always look at me and say, I've only done a few Whipples. And I'm like, great, go to the right side of the table, handle the right angle. Let's see what we can do, because I should be able to get you out of anything, right? So just as we as faculty have to understand that sometimes what we're projecting as a struggling fellow is our insecurities. Okay, so I'm always thinking about with any of our trainees, how am I going to get out of this if they get into the artery? How am I going to get out of this if we ligate, if we're trying to ligate some vessel and it slips? I'm always ready. Those of you that are in the OR with me, when I take the hepatic vein, I have an Alice in my hand in case the stapler misfires and I can grab it, okay? I'm thinking about that. That is not your trainee's responsibility, but you need to let them know what you're thinking. And so then if your trainee's not incorporating, it's on me. It's not on them. Why did I not make this concept their own? What do I need to do to convince them that this is a reasonable way to do this, that it makes sense? What can I do better to make this understandable? Like, I do a Cattell brush. I separate the right colon from the duodenum to find the SMV. I do that because I really want everyone to understand you can do a portocable shunt without entering the lesser sac. How can I connect those dots? Okay, you'll never do a portocable shunt anymore, but just so that you know. And there are two major issues, right? So hardwiring, often trainees that have done other things for a while. One of our trainees had been in practice for many years, and he tells me, I don't know how you tolerated me because I was so hardwired when I came. In fact, he used to say, I need a timeout, so I'm going to go sit in the corner for a minute while I absorb what just happened, and let me come back. And it was hilarious. He's great. And then, just remember, some trainees have a sense of just thinking that they know it all, and you may have to figure out how to get through there, and you've got to connect the dots. So give praise for small accomplishments. I am so proud of you for knowing the chemotherapy for this agent. And usually it's easiest for you to do that when you are calm. So clinic is a good place. Wow, I love the way you read that scan. Okay. Break down the surgery, because your maximum bite may be different to somebody else's maximum bite. So take it and break it down. Terrence, thank you for helping me publish that paper with the illustrations of the Whipple procedure, most cited paper on surgical open science, but it broke it down into steps. And so it breaks down the Whipple into illustrated steps. For me, that makes sense. So encourage small steps. So wow, you enter that abdomen well. You place the retractors. Mikolas used to always tell me, if you can see it, you can do it. And, you took the gallbladder down without entering the liver parenchyma. That's great. And then just a word about research and inquiry. I always say, if you haven't written a paper, you don't know how to read a paper. And last of all, let's not forget the mental toll. Dr. Givarghese has been a very big force in this, because sometimes it's a second victim that is getting us with incorporating things. And remember, in the new world, this is not something that I was used to. But it may be that your trainee is so distracted because you didn't use their right pronoun and therefore cannot move on, or perceived aggression or PTSD. It was okay for me to be slapped on the wrist. It was okay for them to throw a bottle of albumin at me. That's not okay anymore. But there are other things that may have been okay for you that are not okay anymore too. So keep that in mind. It's a gentle compromise because, I like to get everyone involved in the OR and feel important. Thank you very much.
Thank you, Juan, for this amazing presentation. And our next speaker will bring us Latin American perspective to this discussion is Dr. Ismael Dominguez Rosado. Unfortunately, he didn't make it to stay with us in person. He joined us online. So Dr. Rosado is an HPB surgeon practicing in Mexico City at the National Health Institute Salvador Zubiran. He did an International Surgical Oncology Fellowship at Memorial Sloan Kettering and an HPB certified HPB fellowship at Washington University in St. Louis. He is very interested in pancreas disease, colorectal liver mets, and bile duct injury. I think we got his video.
Hello, this is my talk, how I do it, the Latin American perspective. I am Ismael Dominguez Rosado. Thanks to Dr. Tara Kent and the program people of the HPBA of this year. Unfortunately, it will be impossible for me to attend the meeting as my US visa is not ready yet for going to the meeting. So I'm sending this meeting to you guys. I have no conflicts of interest to disclose. And I want to talk a bit of how training is in Latin America and give you an idea of what are the points that I think are important when you are training someone, not just as an HPV surgeon, but in general as a surgeon. In Latin America, there is no general surgery training that is standardized in all the countries. It's pretty different if it's from Mexico, from Argentina, from Central America. In some of these countries, there are only 3 years. In some of them, you do 3 years and you do 2 extra years of gastrointestinal surgery. And some others, like in Mexico, it's 4 or 5 years of general surgery, which makes a very variable the way we are trained. The exposure of different surgical pathologies and the volume in each country is different, and the research experience is also pretty limited, as there's no protected time for this to be performed by the resident. It's very hierarchic still. There is no hours restriction, so residents are pretty working most of the weekdays, and the call schedule is pretty hard. Sometimes they don't have like enough time for going home and having rest and seeing the family, and there's a lot of expectations of work that go just beyond what a surgeon should be doing, like a lot of social work. We take care of a lot of people that have issues, like social issues, to be able to go to the hospital to get all the care that it needs outside of the hospital and inside the hospital. So of course this is a lot of extra work that it's not really related to the experience to become a surgeon. And also the financial struggle. It's hard to live with only $500 a month, particularly if you already have children or you are married and your wife is also in training or working at home. So it's also something that we have to consider when we are having training here. And by the same token, we have some other benefits, like the way we are trained, as there's a lot of requirement of people doing surgery. There's a lot of autonomy for the residents, sometimes more than it should be, but that's a benefit because you really start very, very early to be involved in the OR and to take decisions on your own. And that's good for your training. Also, the exposure in an environment with limited resources pushes you to be able to improvise and to solve problems that may not be expected before the case. We are used to see very advanced and challenging cases, and of course there is a huge opportunity in our centers for doing research and to foster teamwork, and I think the main goal for us is to being able to make a difference in each of our countries after we finish training. Try to make this extra difference that it can change a little bit the way things are done in the hospital and improve patient care. So one of the first things that I think that it's necessary to talk when we when we are training is that we need to try it. We really, just as attendings, we need to try to improve the center where we are training our people. So let's find areas that we can make a difference and contribute, foster relations with other specialties, not surgical, and try to work as a team. Multidisciplinary work has not been very used in Latin America until recent years, and I think it's good that we are now working more as a team with other areas. And this always makes the care of our patients better, and we take better decisions when we work as a team with other people. And it's good to try to implement and evaluate new ideas to improve care. And just to give you an example, this is something that we did in our hospital. This is a technique that I learned from Dr. Strasberg when I was at WashU in St. Louis. It's to use an externalized stent for high risk pancreatodenectomies, small ducts, very soft pancreas, a non-pancreatic cancer pathology, and it seems for us like a good idea to implement in order to decrease our rate of pancreatic leaks and to mitigate the severity of these leaks. So we have implemented this technique since 2016 up to now, and we have seen that this intervention had dropped in a very important way our death related to pancreatic fistula to almost zero, and also has had an impact on the 90-day mortality that has go below 5% in just making this small change. And of course, the rate of the type C fistulas has also dropped enormously from more than 30% to less than 10%, which is a huge achievement thanks to the implementation of this technique that, as probably you know, the cost of a pediatric feeding tube is less than $10. So it's a very cheap and feasible intervention in our countries. Of course, the other point is to try to improve the experience of training. And this is something that I am very proud of it. It's a teamwork that we start with our friends from Chile and Brazil, with the help of Brendan Visser, Adam Alcedi, Dr. Morgan Bones as well. And it's to have a training experience that it's useful for people to train in Latin America, to stay in Latin America, and being able to go to their home countries and start an HPB practice and make a difference. So the people will do this 2-year program, 3 fellows, and they will rotate each month in each of the centers. And the idea of doing this program as a rotational educational fellowship is to each center being able to share what they're doing on. Like we do a lot of bile duct injury repairs. Brazil and Chile do a lot of liver resections and liver transplants. So all these different experience contribute to a fellow that will be able to start an HPB practice in any Latin American country. So far, I will show you the 8 months case logs of our fellows. This is Jose Donizetti, first 8 months in Brazil. As you can see, in Brazil, the case volume is very high. He almost completed the requirements of some of the major aspects of the Fellowship Council, as well as Gabriela Ochoa in Chile and Gabriela del Ángel in Mexico. They have achieved a very good numbers in just the first eight months of the program, and we expect that at the end of the 2-year fellowship they will surpass the requirements in most of the areas that are required for the Fellowship Council and HPBA certification. I can show you here some pictures from Jose and Martin and Wellington doing a workshop in Brazil, and Gabriela del Ángel with Mario Villatova, one of our professors of transplant, and Jose with Professor Mercado doing his first case when he started in the Mexican side rotation. And also here we can see Gabriela Ochoa with Martin and the rest of the Chilean team. And here are our friends that we are working very hard to make this work and to be a source for people in Latin America to get really world-class HPV training that can really make a difference on their home countries. So another important aspect of the training is that the way to train someone is the craft. It's like an art craft. Every person that you're going to train is different. Everybody has different needs and backgrounds, and you cannot expect that everybody will respond the same way. And you need to adjust the process of training, just like if you were building a violin, or you were building something that requires a lot of attention and care, and it's very important to observe what the fellow needs, what are their good skills, what are the areas that each fellow needs to improve, and work over that aspect. Not to expect that fellow will all the fellows will behave in the same way, and all of them will require the same sort of attention. And this is a very important phrase from Dr. Brennan that I think applies to all of us that are training people. Whenever we struggle with a fellow, we always need to remind that this is not about you. This is about the fellows. So we need to find a way to help them and to improve their training experience, and to see why they are struggling, and try to make it work. I think this is very important, not to focus the training on us, but on them. Of course, you can teach them a lot of things, to be mindful, to be exhaustive, take the technical skills that are required to perform these difficult operations, to select and evaluate properly a patient that they're going to take to the operating room, and of course the skills of decision making and postoperative care that are very important. Besides this, the research aspect and how to write a paper is also useful if they want to be involved in an academic practice. And there are things that we just cannot teach, being a good person, have ownership of the patients, having integrity, be honest, and really care of the patients. This is something that's hard to teach. These are values that I personally think come from home, from our family. When we are children, we learn at that stage of our lives all these values, and you can show them by example, but it's hard to really teach someone when they are 30, 35 years old to get some of these values. If they don't have it, it's very hard to make them have it at some point. But of course, you can help them to shape what type of surgeons they want to be. If they want to be mercenaries or missionaries, and for that, it's very important to give a good example of our own lives. It's very important to share with them what we are. Most of the things that they will learn them from books, from papers. Of course, they will learn a lot of things from us in the OR, but it's important to show them what we want them to be, and the good aspects and the bad aspects of practice that they can be involved in the next steps of their surgical life. And as everything in life, life will show them the way, in the good or in the bad way, and this is a good analogy between bullfight and the life of a surgeon. You can believe you are the best bullfighter, but life and surgery, just as the bull, would put you in the place where you belong. So that's why it's very important to show them to be careful, to be very mindful when they decide to take a patient to the operating room. And just to conclude this small talk, always bear in mind that you cannot do it all. You cannot make someone to excel in every aspect of surgical training and surgical care. It's impossible to make someone to be a good surgeon in only 2 years. But you can show them a good pathway that they can follow to improve, to follow the constant improvement and try all the time to be better. We should be mindful to improve the experience of training in our centers by looking what are the things that we need to do to show them better to do the surgeries, to take care of patients. And it's always good to be patient with each person that we are trying to train. This is not about you, it's about the fellows. And just to finish this talk, I want to share you the last words that I heard from Dr. Strasberg in the last case that I did with him during my training, when he told me that once you are my fellow, you're always my fellow. Once you're my child, you're always my child. So training and mentorship is a lifelong commitment and a lifelong experience. Thank you very much.
Thank you, Ismael, for another great talk. And our next speaker is Dr. Morgan Bonds. She'll speak about junior attending perspective, allowing autonomy in residents and fellows. Dr. Bond is graduated at Johns Hopkins School of Medicine. She completed her general surgery training at the University of Oklahoma before attending Virginia Mason's Hepatopancreatobiliary Fellowship. She is now faculty within the Division of Surgical Oncology at the University of Oklahoma. Please.
Thank you very much for the opportunity to speak today. I have no financial disclosures, but I will say I'm in no way an expert on this subject. And I also have a disclaimer. I only teach residents, so that's kind of what this talk is focused on. I don't have any fellows. So what are the challenges in providing autonomy to residents in HPB surgery? One, they have intermittent exposure to our specialty, right? It's not the surgical oncology or HPB or transplant fellows who are with us for 2 years and they're getting constant exposure to the anatomy and to the cases that we do. Our residents are with us for a total of 5 months over 5 years, and those are separated by years at a time. So they sometimes have a little bit of a breaking in period every time they rejoin the service. The faculty have limited opportunities to observe them. So while they're on the service for 2 months, I may only see them operate 10 to 15 times, whereas my colleagues are seeing them the other 10 to 15 cases that they do on our service. So we have to talk to each other in order to get a really good idea of what each resident is capable of. We do complex cases that have very complicated anatomy that they're not always exposed to. And there's not always an available, capable assistant for the resident. So if you have a chief resident on your service that's going to do a case and you think it's something they could do by themselves, but there's no junior resident around to help them, and all they have is a medical student to assist, sometimes that doesn't put them in the best situation to actually achieve autonomy. And finally, you have operating room limitations, right? You have people are always tracking how long it takes you to be in the operating room. How long does it take you to do this case? There are lots of metrics that people are keeping track of that you have to be aware of. And so while you want to give the residents time to learn and do the things they need to do, you also have to be cognizant of those limitations. You don't want to run over time and end up getting 3 cases put on hold because they went past 5 p.m., at least at our institution. So as a junior faculty, what are the additional challenges? One, you're brand new at a new place. I was lucky enough to go back to where I did my residency, so they had some experience with my abilities. But if you're at a brand new institution, people are scrutinizing your abilities. They're looking at your outcomes and how well you're doing your cases. You're also trying to gain your own independence. This is the first time that you haven't had somebody coming in to do the critical part of the case with you a lot of times. So you're also trying to get your own feet under you in these complex cases. And it often requires, for really rarely exposed cases, like your hilar cholangiocarcinomas and things like that. I have seen those cases, but I've never actually completed one because they've never actually been resectable. So if I get one of those cases, I often need assistance from my senior colleagues in order to complete those cases successfully. So I was interested in what is the literature out there on junior faculty and influence on resident autonomy. And there's this paper in JAMA Surgery from Dr. Minter's group that actually looked at what factors into residents getting autonomy in the operating room. And they actually, what I really liked about this paper is they had external observers who were, non-biased, had different levels of experience and different expertise. And they actually found that the faculty experience had no influence on whether the resident got autonomy in the operating room. But what they did see is what faculty entrustment did. So faculty entrustment, they basically described as how the faculty and the resident interact with each other. It's the communication before the operating room, in the operating room, and how much the way that you interact with your resident actually influences how much autonomy you give them. And this was actually also seen on the direct interactions as well. So what does that mean? I think it means that it doesn't matter what level of faculty member you are, it's more about your teaching style and how you interact with your trainee on whether they get autonomy. Now, this is to be compared to this study, which is actually from an anesthesia group in Europe. And this was more of a subjective resident and faculty reported interpretation of who gets autonomy and when. And that bottom line, which is line A, is actually what the attending thinks that the resident at each level is proficient, what their proficiency level is. The top line, which is actually line B, is what the residents felt they were capable of. And line C is the middle one, which is what the amount of autonomy and what they were actually asked to do on a day-to-day basis. So you can see, especially in the earlier years, the attendings really didn't think the residents had a lot of proficiency at a lot of things, but they were asked to do things above their proficiency level anyway. And it was actually closer to what the residents thought they were capable of. And then they looked at factors, the same paper, they looked at factors that they felt influenced the granting of autonomy. And in this one, on this more subjective evaluation, about 15 out of 20, or 15 out of 19 that were surveyed felt that the experience of the faculty member did influence the granting of autonomy. But there was not a lot of feeling that the procedure being specialized or subspecialized had an influence. Only about 3 out of the 19, or 3 out of 10 faculty members felt that it was. So to me, this says, in comparison with the objective observers that we had in the last study, that even though no matter what's actually happening in procedures in the operating room, sometimes it doesn't feel that way to our trainees. So how do I do it? I kind of broke it up into 4 different parts. I think it's important to have a good understanding of what expectations are before you even get to the operating room. So I ask the resident, how comfortable are you doing this case? And I honestly think as a junior faculty member, especially one who trained there, I get a pretty honest answer, maybe sometimes more honest than what they would say to a senior faculty, because they would feel like they were getting a little bit more judgment from them. And so they'll tell me, say it's a Whipple. I've had a lot of residents tell me I don't feel comfortable with any part of this case. And so I have to say, well, let's take a couple steps back. What is the first step of doing a Whipple? Mobilizing the hepatic flexure. Do you feel comfortable doing that? Yes. Okay, so we go through each step and I make them tell me which part they feel comfortable with. Because sometimes they just need a little bit of a confidence boost that you can do part of this procedure without me. What do you want to get out of this case? I think is very important. Not everybody wants to go into HPB from my residents. Not everybody wants to do surgical oncology. So I think figuring out what exactly they want to get out of it, especially I think if it's, my whole goal for them is to be able to do the things that I think a general surgeon should be able to do and describe on their oral boards. We review the imaging together and make sure there's nothing that we need to be looking out for and make sure that they've reviewed the imaging beforehand. And then I explain my expectations for them in the case. I think you should be able to do X, Y, Z. If they disagree, we have a discussion about it. And I think it's also important that I explain my expectations for myself in that case, especially if it's one of those complicated, rare cases that I talked about earlier that I feel like I'm going to need help with. Dr. So-and-so is going to come in at this part of the case, just so everybody understands that during that part of their case, there's probably going to be very little autonomy for them. So intraoperatively, I broke this down into technical and decision-making. So I set a time limit for specific tasks. A lot of times I will leave them to do the first part of like a Whipple, say, mobilize the hepatic flexure, cochorize the duodenum, get into the lesser sac. And I leave them, I say, you have an hour and a half. That way we don't run over time in terms of the OR expectations. And also I tell them it's not expected that you finish all those things. We'll just see how far you get. If I can, I leave the room for non-critical parts of the case. I don't know about anybody else, but I cannot keep my mouth shut if people aren't doing it the way that I would do it. It doesn't necessarily mean that it's wrong the way they're doing it, but if I can leave the room and they have an assistant, I do. I'm always there for the critical parts of the case. So if it's a gallbladder getting the critical view of safety, I'm in the room because I want to hear the way they're thinking about things. If I'm the only available assistant for those parts of the case, I make sure the the resident stands on the operative side so they can actually get experience doing the dissection. And I allow them to struggle until frustration surpasses education. There's a lot of debate, at least in my department, about, you need a level of frustration in order to grow, which I think is true. But at some point you get too frustrated that you actually don't learn anymore. And I think there are things that I maybe do differently or can teach them to make it easier for them. So I always ask, instead of just telling them what to do, I ask, may I offer suggestion on how you can make that easier? And a lot of times the yes, please. And so it's just a new technique that maybe somebody else doesn't do or nobody showed them before. And even though they're a chief resident and theoretically, yes, they're going to be on their own, if I can show them a way that's easier, I think that's worthwhile. So decision making, I think my chief residents probably hate me in the operating room because I make them talk a lot. So I ask open-ended questions at every decision point. I make them defend their decision. And if I have an alternative pathway, we'll discuss it. And I want to emphasize to them that there are multiple acceptable pathways. You don't have to do everything the same way. That would be safe. That would be fine. We can do it that way. Or if I feel strongly about it, we're going to do it my way. But I want to emphasize to them that when you're in the operating room making decisions and out of the operating room making decisions, a lot of times there's not one correct answer, which we get really used to as people who have been in education for as long as we have. So in the post-op period, we do a one-on-one verbal review after the case, right afterwards. Our residents dictate our cases because I think it gives them experience describing the case, what they did. It reinforces kind of the steps of the things that we did. I review and edit the dictation, and then I provide that resident feedback. I wouldn't have said this, we did this, et cetera, et cetera. We use Simple at our institution, so I complete their Simple evaluations. They have something kind of solid to hold on to review later on. And then if they have another case that's similar to what we did, even if it's not my case, I'll review what we did in terms of the next case that they're doing so that they have something to apply to their next case. So to conclude, you've got to actively practice entrustment and autonomy. It's about, actively engaging with the resident. Every resident is going to be different. They're all going to be at different levels and they're all going to have different confidence levels. I allow autonomy based on the resident self-evaluation. Don't allow them to undersell themselves or oversell themselves. Openly discuss the expectations of learning of the case from both sides, including time limits, my limitations and expertise on certain things. And I give them enough space to make mistakes that I feel comfortable fixing. Thank you for time.
Okay, and to close this session, we're gonna have the fellow perspective. What I'd like my attending know, Dr. Kate Stakehouse. Dr. Kate is training at the Cleveland Clinic Foundation, where she had her residence in surgery, and also at Beth Israel Deaconess Medical Center, also residence in surgery. Please.
Thank you very much for the opportunity to present. My name's Katie. I'm the Cleveland Clinic HPV Fellow this year. I have no financial disclosures, but I do want to say that a lot of the other fellows, most of which are in this room, contributed to this talk, and they gave me their perspectives and their ideas and their opinions, and I incorporated that. So my disclosure is I'm going to do my best to be the person to kind of represent us as a group up here today. So I'm going to talk about three major topics. One is learning in the operating room, and that was a perfect transition, I think. So thank you for that. I'm going to also talk a bit about diversity, equity, and inclusion in HPV surgery, and also briefly about job search and support with that.
So first with intraoperative learning, this is something that someone submitted when I was looking for people's perspectives. I hope my first time doing the uncinate dissection is not the first time I'm doing it alone. And this is a specific example, but I think that this sentiment represents a sentiment that's pervasive among fellows. You want to be competent and safe at the end of your training, if not outstanding. And there's an underlying fear that you won't be able to be fully independent at the end. You want the opportunity to prove to yourself that you can do it in a safe nest before you fly on your own after fellowship. So this is a survey of graduating HPB fellows and their program directors, and it's about their perceived ability to perform independently these different procedures and operations at the end of their fellowship. What I took mostly from this is that, honestly, kind of across the board, the fellows and the program directors thought similarly about their abilities to do these independently. And interestingly, I thought when they did disagree, it tended to be that the program directors thought that the fellows were more capable than they thought of themselves. So see one, do one, teach one. We hear this all the time. It's obviously relevant, but I would propose maybe a different way to think about it in the operating room. So one is see one, see how it's done, see how a particular surgeon does it. Then do one, do it with a lot of guidance. Then maybe do another one and do it with less guidance. And then do another one with minimal guidance. And maybe take someone else through it. And then go back and say, I want to see it again. And I want to look at what you did and figure out why that part was hard when I tried to do it myself. And I think there's value in kind of making that an iterative process. Autonomy is important for transitioning to an independent skill set, as we've been talking about a lot in this session. And I think if I kind of polled all the fellows sitting in this room, I think every single person would say, I want more autonomy. I want more time by myself in the operating room. I want to do more by myself. I want more opportunity for that. I think that that's great, but I do want to say that guided autonomy is important as well as you're learning more complex skills. We came to fellowship to become excellent HPV surgeons. We weren't, or I should say, most of us aren't that when we're starting fellowship. That's kind of the goal. So we're here for your expertise, and we want you to teach us, and we want you to teach us your way of doing things. And so how do we do that? Sharing is caring. You can share the right angle. You can do different parts of the case. You can still be there while the trainee is doing the dissection, and you can provide guidance, and you can say, no, do it this way instead. And I think all of that is helpful, and that's the whole point of training. And communication is key, right? So I think effective learning happens when expectations are set on both sides of the table. As the attending, what are you expecting of the fellow that day? And as the fellow, what are you expecting to learn that day? What are you hoping to get out of the case? I think that's an important conversation to have. And in that same context, I think it's important to set goals together prior to an operation. And this allows you to kind of take an operation, split it into steps, and figure out who's going to get the most out of what parts of that operation. And that allows you to optimize your learning while still maximizing efficiency and getting through a really busy day in an efficient manner. And I think debriefing is also really important. So whether that, it's often difficult to do that at the end of the operation. I know that, you're often leaving the operating room at different times. And so it's difficult to do it right in that moment. But if it's not at the end of the operation, maybe at the end of the day or the end of the week or in some sort of structured format, I think having a back and forth about feedback and debriefing is a really important aspect of it as well. So now I'm going to change gears a little bit and talk a bit about diversity, equity, and inclusion. So in 2021, the AHPBA SWAT Task Force did a cross-sectional survey of AHPBA fellowship graduates, and they looked at the strengths, the weaknesses, the opportunities, and the threats that are facing fellowship training going forward. There were 4 major themes that came up through this, and diversity, equity, and inclusion was one of those 4 things. Fellows endorsed a range of perspectives on the topic, and people in underrepresented groups tended to identify it as a problem more frequently. Many people felt that the lack of women and underrepresented minorities in surgery and in HPV surgery feeds into underrepresentation of these folks in HPV fellowship programs. So this was a survey of program directors and faculty members who have a role in choosing between HPB fellowship candidates during the application process. And they self-reported, what do they value? What do they think is important in terms of choosing, excuse me, one person over another for the fellowship position. And across the board, every single person said that gender and race do not play a role in deciding who gets that fellowship spot. Unfortunately, this doesn't jive with the demographics of both general surgery residents, HPB fellows, and HPB faculty. At the time of this study, 42% of general surgery residents were female, but only 24% or 22% of them were going into HPB, and 24% of the faculty that have responded to the survey were female. In addition, there were 2 Black or African American and 1 Hispanic fellow at the time of this, and there was 1 African American faculty and 1 Hispanic faculty that was represented in the survey. So there's an incredible amount of work that needs to be done here. But there's lots of opportunity for progress. So proposed solutions to this problem talk about increasing the numbers of these underrepresented minorities at all career levels. This is obviously going to take a lot of time. It takes time to build that. But in the immediate term, we should be supporting these individuals, providing opportunity in leadership positions, increasing recognition of accomplishments in a public forum, and creating a community that's supportive of all its members. On a practical level, supporting individuals can go a long way. Have equal expectations for male and female trainees. That impacts their training and it's important. Create an environment that creates healthy work-life balance. And changing these interpersonal interactions is ultimately what's going to change the culture. I don't mean this to be all doom and gloom. I know we have so much progress to make. I wanted to highlight that a lot of progress has been made within the AHPBA. This is the group of us at the annual fellows course in Charlotte this year. And for the first time, it was half male and half female attendees in that conference. So that was really fun and really exciting. And I think there's been a lot of progress made in that. But my point of this is, as fellows and as a group that I'm trying to represent, we want you to know that we're committed to this mission and we want it to be prioritized so that we can build a diverse and inclusive next generation of HPB surgeons. And then finally, we'll talk about the job search. It's generally perceived that there are a lack of HPB surgery opportunities and there aren't enough jobs for the graduating HPB fellows. It's thought that it's frustrating that a lot of jobs go through mentors and direct connections and they are often not advertised to the public. It can be very challenging that there's not really a great centralized place for job opportunities to be found. And the job market can be slim for folks who want to go into academic HPB surgery. So this was the same SWOT analysis done by the HPBA a couple of years ago. This was a second of the 4 priorities that were identified here. In the vein that there aren't enough jobs for graduating fellows, despite this fear being prevalent among fellows, most fellows had 1 or multiple job offers by the time that they graduated. And almost everyone was still in the same job at the time of this survey. Granted, it was short-term follow-up, but that perhaps suggests that there is job satisfaction in that job that you ultimately do accept and that you ultimately take. Most of the people in the survey described finding a job after fellowship as moderately difficult, but even still, they said they would take the same pathway when they were asked and they would do their training exactly the same way. So how can we make this better? I think as a fellowship group, we appreciate the mentorship and the promotion that comes from the folks that are training us. And it's often the way that we're finding jobs. So please keep doing that for us. We really appreciate it. I think as a society, we could move towards improving the centralization of job opportunities. And that would benefit, obviously, not only the fellows who are looking for jobs, but also the institutions that have open positions to increase their applicant pool. In the end, we want you to know that we need support from you and from our mentors and those in leadership positions. And we appreciate everything that's being done so far, both in terms of our teaching, our training, and moving forward with our career. So I will just leave it at that and say thank you, and hopefully we have some time for discussion.
Well, Well, that was fantastic. Really appreciate all the speakers and the time that it took to put their comments together and the perspectives, which are really invaluable. And for those of you who are early in your career, a lot of the advice and perspectives are crystallized here as a result of probably decades worth of experience in the School of Hard Knocks. So I hope that was helpful to you. I'm going to start the question and answer period, and then in a moment, I'll take a roving microphone and hopefully evoke some questions from the group of you. But I'd like to start with Dr. Moulton. Hi, Dr. Moulton. We can see you on the screen. Thanks again for tuning in. As I, again, always enjoy your talks, as I was thinking about the theoretical approach to teaching, I heard the term flow, which is, of course, that element that we all like to enter, and particularly those of us in an attending position. We're fortunate after years of doing the same operations, we can enter that phase of flow. But as we are in the process of education, we may also be distracted in some ways, and we get out of that flow. So my question to you is, as we teach our learners in various stages, how do we inculcate that sense of flow and joy from the actual operating, the clinical event in the operating room?
Yeah, I think it's difficult as a trainee. Can you hear me okay?
Yes, we can. Thank you.
I mean, the whole nature of cognitive flow is when something that you're doing is, you're challenged by something that you're doing, but you actually know how to do the skill well. And so as you learn, you become increasingly able to experience flow. If you're actually operating at the challenging part of your skill level. We studied the cognitive flow, and we recognized that we don't just experience cognitive flow in surgery. I think it's really important to start thinking about team flow. And when you're operating with a trainee, I think most surgeons, and I'm not sure about the trainee aspect of it. I think trainees are starting to understand and feel flow. But I think as a surgeon, there's certainly times when I experience flow in the operating room, and the trainee has a lot to do with it. It could be make or break whether I'm experiencing flow actually in a particular case. I think recognizing the phenomenon individually, recognizing what it feels like, whether it's in surgery or in a sailing or some other kind of endeavor that you enjoy doing. I think recognizing that in yourself, and then trying to promote it, understanding what promotes it in surgery and what takes away from it in surgery is important. But it's a big topic. It just means that we each should be, aware of, what can bring on flow. We can actually certainly control the environment so that we actually encourage flow to occur. So I think that's actually very important. But the distractions that happen in an everyday OR is not the place where you experience flow. So I think part of our mandate moving forward is to try to help us enjoy our work and figure out what it is that we need to experience flow.
Dr. Moulton, now I'll just roam the room. Here's the question. Thank you.
So I guess I will. My name's Kenneth Lee. I'm from University of Pennsylvania. So I ask two things that are probably going to be impossible to briefly to the panel. But first question is, and Rohan kind of got this, but people come in at different levels, and yet we tend to put them in the same machine as though they're all equivalent. And so how can you alter that? Like, how can you adjust for the way that people come in? And then the second question is that I think in surgery, we sort of assume or rely on the fact that people can learn by osmosis, but not everybody can take the same from certain encounters. So some people you can tell immediately do not get the same amount out of an operation or a patient encounter, but the patients keep coming and the operations keep coming. So what parameters can you change when you encounter somebody who clearly is not learning from osmosis the same way that do?
Thank you very much for that question. I think that one of the things that you're alluding to is, some of this needs to happen in prior to fellowship training paradigms. And so potentially the EPA framework might help with that in general surgery residency. I'm not sure, but that is a possibility. I think also, Dr. Lee, you're alluding to the fact that it's the rate of learning that, I alluded to in that graph. And then also, we have to figure out what the LD50 is, unfortunately, for our most difficult trainees, right, in order to make it safe. Because what we want to do, what we did for Lap Coley, was we didn't think about this, but having lived through it, we knew that the risk of bile duct injury was around 40 cases. And we said that we were going to do that during residency because most residents finish with more than those number of cases. We have to figure out what that is for HPB also and make sure that we cover that with some volume and repetition during fellowship is my thought. I think you're right that we're not good at realizing that some people just are not cut out for this. And the problem is that we're kicking the can down the road to hurt them from a mental health standpoint. And so sometimes it takes a lot of courage to really sit down with that person and say, is this really what you want? Should we nuance this a little bit differently? Should we look at one area of HPB that may be more relevant or something to that point? I hope that kind of got to the answer, but those are my thoughts.
I would just add, I think sometimes, especially when you have a resident that you're worried about or you think isn't quite at the same level as everyone else, I think having a conversation with your colleagues and seeing if they are seeing the same thing can be helpful. Because when you're all on the same page and feel like the resident needs to work kind of on the same things, it's easier to reinforce the message of what needs to be worked on rather than just one person saying it or you sitting, especially me as a junior faculty member, I feel like, well, maybe it's just me, maybe I'm not helping them the way they need to be helped. So talking to my colleagues and hearing their opinions on a resident is helpful. And then I tend to be the challenged resident go-to person in my department. So I have a lot of individual meetings with people who are not maybe learning by osmosis or not learning the way that everybody else is. And we have, one-on-one long discussions about what do you think you're missing that everybody else is getting? This is the feedback that we've gotten from your faculty. How do you see it? And then sometimes it's just they learn differently. And so you've just got to kind of tap into the way that they learn best.
Nauman Ali from Cleveland Clinic. Thanks everyone from the panel for your talk. Dr. Jayaraj had mentioned that in his talk briefly, and it was maybe a bit of a controversial thing about the whole acute care surgery mindset phenomenon that, when I was going through residency, I was like, oh, we had the 8-hour work week and the old guys complained about that. Now we see the residents going through and rotating a lot on the acute care surgery and kind of that mindset, not just of hours, but maybe mindset of taking care of patients and shift to see. And the vast majority of trainees that we're going to train are not going to do any HPB surgery at all for it. And so how do you feel is the best way to try to get residents out of that mindset of the acute care phenomena of just, I take care of the patient right now, then I go home and someone else takes care of it, versus the majority of their real life practice is going to be not the shift work mentality and not doing HPB. How do you balance that?
So I didn't actually talk about the second part of that curve, which was what's happening with the faculty. Because I actually think with residency redesign and acute care, it wasn't as much of a problem until the faculty also were rotating. So I was sitting next to somebody at the airport who got a call, and he was a chief resident, and it was a horrible discussion about somebody dying and how it wasn't his fault because he only admitted the patient, but somebody else operated on the patient and a third person took the patient back. And so nobody was involved because there were 3 faculty members and 3 residents involved. And I just thought to myself, my gosh, this is awful, And unfortunately, and again, not due to any fault of the trainees themselves, this is becoming reality for a lot of your residency, that everyone's rotating, right? Not at every place, but in a lot of places. I think that comes to fellowship, unfortunately, Noman. I think that it's coming to the fellowship where you're learning how that complete continuity of care occurs. But I'd love to hear what Dr. Stackhouse thinks, having, been closer to this.
I think the acute care surgery model is obviously a double-edged sword. It's good for quality of life, but it's not good for patient care. I do think that as a fellow, I've gotten to see the same patients over and over again. Even in the middle of the night, often getting called about them, and it's the same person from pre-op to intra-op to post-op to, either long-term follow-up or complication, and you see the same person over and over again. And I do agree. I think it changes your mentality and it starts to get you prepared for who your cohort of patients are going to be and how you're going to take care of them. But I definitely think fellowship was a bigger jump in that than residency for sure.
Do you mind if I steal your mic?
Yeah, I think that fellowship doesn't always hit the mark either, depending on how your fellowship's designed. Like, I think we can try to draw people back into some of the joys of having longitudinal relationships with patients by highlighting, when you're seeing someone back in clinic, like, oh, I saw Mr. Smith. We transplanted him 6 months ago. He looked awesome. And trying to engage people from sort of a positive aspect. And then another way that I think we do it a little bit in our group is when we reflect back on cases, the expectation is that even if the fellow has not seen that patient in clinic, they know sort of what has happened since the patient left the hospital. So it's not just that they were discharged with X, Y, or Z problem and someone else then dealt with that. They continue to follow it.
Hello, Rob Simon, Cleveland Clinic. Question for everybody. How do you think video review can play into training for residents and fellows?
Dr. Moulton, do you want to take that video review? Just my comment is that, I think that, again, breaking the surgery up into key components and understanding where you are comfortable, but those critical moments where Dr. Moulton states slow down, because Caroline, I have your voice in my mind every time as I ligate the right gastrophloic vein, and know that as I'm doing that, that is a critical moment where it can tear off the SMV and I could start, going crazy instead of just putting my finger on it and taking a minute and taking a 5-O-proline, and taking a breath. But I think figuring out, and I'd love Dr. Moulton's thoughts on where in the surgery are the moments where we should focus on this. And just to use a musician analogy, I also believe that simulation is key here. Any musicians in the audience, the practice should be the simulation, the surgery should be the concerto, right? And so why are we practicing when we are really performing the concerto? My daughter's a musician and says a lot of people practice while they perform the concerto too, but especially on the oboe side. But anyway, Dr. Moulton.
Yeah, I'm all for more video. I think the video is a bit tougher when we do open HPB because it's harder to get, good crisp videos that you can, without hands and heads and everything involved. But I think that's getting easier and better. Certainly laparoscopic surgery. I think we underutilize video feedback. I think that's what you're talking about. And I think coaching is underutilized also. So, going forward, if you think about, the reduced hours, we need to become more explicit with training. We need to value every OR hour that the trainings are in the OR. And I don't think we do it enough. I don't do it enough. It needs to kind of become part of the system. Military training or people who are fighter pilots, they spend like 15 hours prior to 1 hour flight time thinking about and planning and preparing for, mentally rehearsing for a flight. They spend the 1 hour in flight and then they'll spend the same amount of hours afterwards debriefing and because flight time is so expensive. I think it's similar to that with us. I think we should be maximizing the OR, but we haven't got it in our system yet. I think we need a framework for understanding what it is we're rehearsing. I think maybe the planned and unplanned moments can come into it there. We need to understand how do we maximize the teaching and judgment in those moments in the operating room. And then we need to have a structure where we debrief. But, you know, the system gets in the way, I think, with everybody and time. You know, maybe the resident being a bit more proactive and the staff being more proactive also will actually help. But I think any bit of teaching, coaching, I think it's underutilized. I think it's coming, but it's not been used as much as it could be or should be.
Okay, thank you, Dr. Monto. Just another question. We are already over time, okay?
Oh, thank you. Thank you. Thank you to the panelists. Wonderful discussion. It's nice to hear everybody's perspective from different stages of their career. This is a bit of a personal question. When I started my journey as a faculty member, I had trainees doing all parts of the case. A PGY 4 would do an entire Whipple under strict guidance. A PGY 3 would do a total pancreatectomy under strict guidance. A 5 would do a right hepatectomy under strict guidance. And I thought I was doing great. 3 months later, I was rated among the worst faculty members in the staff. I was told that I maintain a very stressful environment in the operating room. Now, 2 years passed, I let them do less. We still talk the same amount. I feel like I've taken over a lot of my case, but I'm rated much better and feedback is much better. I can't tell if I am doing more wrong now and expecting less of them, or was I more wrong then? Any guidance in this, please?
Well, I think, I mean, when you talk to residents, everybody kind of wants the different things in the OR. So some people probably loved that you let them do the entire case, while others found it very stressful. So I think a lot of times, I think somebody mentioned it, I think you mentioned it, they want to be taught how to do the case your way. They want to be taught your tricks, your tips, your things for those critical things, right? So I think, you know, it's great to talk to them, but sometimes they want you to just show them how to do something. And I think setting those expectations before you go to the operating room of what do you want to get out of it? This is what I expect from you. This is what I'm going to do, helps kind of manage that stress a little bit.
I would just add that all of us straight out of training tend to want to give more. And then as we get more mature, we step back and do more as faculty. And it's part of learning the critical sort of those key portions where you have to slow down and do it yourself. But I think part of this that you're learning is your maturity as time goes on, and perhaps they're sensing your level of intensity coming down also, despite how much of the case they're doing, would be my suspicion. But for the trainees, remember, you don't have to let everyone do the whole case as soon as you get out of your training. In fact, you should do the case to begin with.
Can I just add something? Can I add something there? Can you hear me?
Yes, please. Yeah.
I think it's really important when you say that you let them do the whole case. We have to be really cognizant of what that means. I think as a junior trainee, you think you're doing the whole case, you're doing a whole Whipple, but as you become more senior, you realize you're doing very little of that. I think it has a lot to do with how, that control dynamic piece we were talking about. We can control what they look at, we can control what they're seeing, we can, even control the dissection. And then as they get more senior, you can kind of withdraw some of that and let them develop the situation awareness so that if you weren't there, they are confident and they're doing the same, but you're supervising. It's a very kind of subtle difference, but I think, we just have to understand what we mean by, we're letting them do it. It's not just a one-time fits all, it's a dance where you're kind of pushing and pulling a little bit. So maybe that's part of it.
I think also if you have someone that can help give a different perspective than just the trainee feedback, it might be helpful. If there's someone that you trust that you could say, hey, I'm doing this case today with a resident, would you mind just poking your head in and seeing if you have any thoughts about the way we're interacting, because I think sometimes we don't necessarily have a good perception of our own behavior, and to someone else it may be glaringly obvious where there may be a disconnect.
Okay, I think with this, we come to the end of the session. This is a wonderful session. I want to thank you all who showed up for this session, and also our speakers for their great talks. Thank you.
Thank you.